Hello everyone. This is Dr. A. We're going to look at Chapter 7, which is over the Laboratory Quality Management System. So this is a really important chapter of quality. Quality is an integral part of the lab, but it's definitely an integral part of clinical chemistry. All right, so let's do a little intro. The reason quality matters is because you want to turn out reliable and accurate test results in a timely manner for your patients. So not only do you want to turn them out quickly so that they can be used for treatment, and sometimes it can be a matter of life and death to get these results out so that they know what interventions are needed for the patient. But if what you turn out is total junk, and it could end up harming that patient. So all of this is really important. So in order to ensure quality, you have to have standards that have to be met. And because if you don't have a standard, if you don't have a goal to target something, then you don't know where you're at. You don't know if you have quality or not. And so you have to compare the performance of the lab to a set standard. So there are a couple different types of standards. There are standards that are set by the ISO, which is the International Standard Organization. And these are more related to manufacturing standards, having to do with the analyzers, calibrators, controls, and all of these things we're going to talk about. And then there are other standards that are more specific to the lab that are set by CLSI, so it's the Clinical Lab Standards Institute. And then every hospital, every lab, every clinic, anywhere there are labs, there are quality management systems. And it is a big system. So this is beyond just quality control on your specific analyzer. This has to do with, it's a systematic approach that considers absolutely all the elements of testing in the lab, all the processes. So every aspect of the lab is related to quality. And this can, for example, staffing shortages. If you don't have enough staff to run the lab, then it can impact quality because you can have delays in blood getting collected if you don't have enough phlebotomists. You can have delays in the test results coming out if you don't have enough techs to do the work and stuff. You need reliable instruments. If your instruments are old and always breaking down, and you have delays in turning out results because of that, or you can't even do the test, that is a problem. The space that the lab is in is also important. You want to have enough space to be able to work safely and not be crowded and all of that. We're going to address a lot of these issues. And a good quality management system should be able to detect your errors that are occurring in the lab before the results are sent out. You really want to catch errors before they land on the nursing charts or the electronic health records where the doctors can see it, because then if they're acting on erroneous results, harm could come to the patient. And obviously things can be called back from the chart and all of that, but sometimes if you don't catch it fast enough, whatever, like I said, some intervention, something could happen and harm could happen to the patient. So the idea of a quality management system is you catch things before they're sent out, so you don't have to retract them later on, and you don't negatively affect your patient care. Okay, so we're going to look at a bunch of the different aspects of a quality management system. So we're going to look at facilities and safety, customer service, process improvement, which is CQI, which is continuous quality improvement, everything related to document and records, occurrence management, and then assessment of the lab, so lab proficiency testing, purchasing and inventory, and then we're going to look specifically at process control, so your sample management, quality control on specific analyzers, method validations, and all of that. We're going to look at information management, equipment, personnel, organizational structure. We're going to do all of this are part of your quality management system. So there are a lot of moving pieces in here. So let's start with facilities and safety. Okay, so on facilities alone, simply, you would want to have a lab that is big enough to have the staff in there and all the equipment and everything flow around the lab and move around. Everybody's comfortable and able to work, and they're not bump into each other, or there's not a bunch of cords that you trip on and safety violations and all that kind of stuff. Okay, so let's talk about safety. So employees are responsible in part for safety. So their responsibility lies in following the safety protocols that have been established by the lab and wearing the PPE. Okay, your manager can't walk around behind a tag making sure that you are, wearing your gloves, or if you have to have glasses or shields and stuff like that, that you're doing all of that. It's your responsibility to do it. It is their responsibility, however, to make sure that you have gloves that fit, you have PPE that fits, you have what you need to follow those safety protocols. Management in your employer then is also responsible for identifying the risks that are in the lab. They need to create appropriate training so that you know what those risks are and how to mitigate them, how to work safely in the lab. They need to provide a safe work environment so that, again, you're not tripping over loose cords and there's not spills everywhere and all kinds of, bad things that could affect your health. And then your safety training needs to be documented. So there's usually some kind of yearly thing that has to be done. Some of this now can be tracked electronically. We had stuff in a binder that had to be done and tracked and checked and all of that kind of stuff. It's very important to document all of these things because these are things that when the lab gets inspected, they are looking for. Okay, so little scenario on the poll if you're in class. So if there is an accident because an employee didn't use a machine properly and the employee has no documentation of training on that machine, then whose fault would it be? So answer me that. What do you think in that scenario? Okay, let's talk about instruments. So there are a lot of different instruments in the lab. Obviously, the chemistry analyzers are big analyzers, but there are also some smaller analyzers in the lab, and you want a properly performing instrument will give you good results. And so you obviously are going to talk about all the stuff that goes into a properly, performing instrument. Sorry, lost that word for a second. And but you also have to make sure that the instrument that has been selected is appropriate for the lab. So you want something that's, it's kind of like the Goldilocks principle, not too large, not too small. It can do the right amount of work involved for your work volume, the volume that your lab handles. Some labs that have really, really high volume may have multiple chemistry analyzers to handle their volumes. But if you have a lower volume lab, then you may not need one of those big floor models. You might could go with a smaller benchtop model. You also are going to want to consider the reagent cost and other ancillary costs. So reagent cost is straight up, how much reagents are you using for the test that you're performing? So sometimes some analyzers, like the machine itself, might be, low cost, but then they get you with the reagents because you need those reagents, and so the cost is there. Sometimes you can do even like reagent rental of an instrument where they basically give you the instrument for free, but you pay for it through the use of the reagents. Ancillary costs would be things like if it has disposable cuvettes and you have to buy that, the cuvettes, and you have to replace probes, or you have to buy pipette tips and stuff like that for that analyzer. Those would be ancillary costs. They're not specifically reagents, but you have to have them for testing. What's the maintenance on the analyzer? How extensive is the maintenance on the analyzer? How often does it have to be done? Obviously, for an analyzer, there's usually some form of daily maintenance, often some form of weekly, then monthly maintenance, and then how much time does it take to do it and to stay up and running. And then is there tech support available when, that's something that's important when you select your instrument. Do you need 24/7 tech support? Do you just need business hours tech support? So like if you were in a physician office, you can probably get away with a 8 to 5 kind of tech support. But if you are in a hospital lab that's running 24/7, then you're going to want 24/7 tech support. And what's the response time and sending a tech out there to fix your machine and all of that. Then also what's the testing menu, and that also will be driven by the type of lab that you have and the need of the physicians and the patients in that setting. And then can that instrument obviously accommodate your testing menu. So all those are things that go into selecting an instrument, and getting the right instrument in the lab is really important to quality. Okay. Preparing the instrument for use is also part of quality. This is often done by the manufacturers. So let's say you buy a new analyzer, or you're replacing your analyzer, your old analyzer with a new one. The company that you're buying the analyzer from will send one of their techs, and they will help get the machine up and going and doing all the work that it takes to get it running. So there are things like, for example, every single test, once that machine is installed, every single test that it runs will have to be calibrated because it's the first time it's running all of this stuff. You also will need to do parallel testing. So it's often a scenario where the old analyzer is still there, the new analyzer is in a location not too far from that old analyzer, and you want to take samples and then run test panels on the old analyzer and then run them again on the new one, and do this for a bunch of patients and compare and see, is the new one running on par with the old one? Are you going to have to shift some ranges? Are you going to have to alert your physicians that we have new ranges because we switch analyzer methods and all of that? How is it affecting your patient results? And so, because if you don't communicate with the patients and tell them, and one of your tests is running higher on the new analyzer, they may think, oh, there's something wrong with my patient, when in fact all that happened is you switched analyzers. You need to do precision studies also. Again, often that's done by the person that comes and installs it. Precision studies is where you run the same sample over and over and over and over on a specific test, and you should, if it's one test on one sample, you should get the same result over and over and over and over. And so how often, are you getting the same result, or are results varying every time you run it? So if the results are varying every time you run it, then you might have some precision issues and stuff like that. And you can do that also running several in a row, running water in between to see if you're getting a true zero, if there's some carryover. Like, there's all kinds of stuff that has to be done to make sure that everything is ready to go and you can turn out quality results. So maintenance on the instruments. Every instrument in the lab has some preventative maintenance. It is determined by the manufacturer. It's usually very clear what needs to be done, but it is the responsibilities of the techs that are on duty to do that maintenance and actually perform it. If you don't perform the maintenance adequately on the analyzers, then the analyzers can break down more often, which then leads to more downtime and lower quality results and problems in the lab. Techs are expected to troubleshoot equipment problems, call the hotline to tech support and all of that when needed. Oftentimes, if it's a jam of cuvettes or something, they're pretty easily cleared. Sometimes it's something that needs to be replaced, that it's a pretty easy part switch or something like that. So the bigger fixes, the harder fixes, then usually involve a tech support coming in and fixing it for you, bringing the part and all of that. Labs should always consider having a backup analyzer or a backup testing method for when their bigger analyzer goes down. This is especially true for tests that are critical to patient care. And so there should never be an instance where you say, I'm sorry, I can't get your potassium or your glucose and all of that. Like, there should always be a backup analyzer that you can load those tests on, that maybe you don't normally run them there, but you can. Or a different method. And even if that method is a point-of-care method, there should be something that you can go to if your instrument is down to get results on critical stuff for your patients. Also, random errors occur on analyzers. It can have a variety of sources. Some of that can be linked to instrument maintenance if cleaning is not done appropriately, and it's because maybe probes are dirty, or some area is dirty, and that's causing some random errors. You, again, just as I mentioned in the previous slide, you want to negotiate and know what your instrument service contracts are. Basically, they go from no contract, which that's usually not good, to business hours only and no weekends, to 24/7, 24/7, 365, like all the time. And of course, there are different prices to those things, and it would depend on your setting and how, are you running 24/7 or are you just running during business hours? And then any equipment maintenance has to be documented. Basically, it's just like everything in the lab. If you don't document it, you basically didn't do it. There are usually ways to log it. Now you can even log it on the instrument computer itself. Often there are clipboards or things around where you can initial what that you have done it and what you have done. And you can also want to keep records of any kind of troubleshooting, parts replaced, and all of that. You should be able to track everything that's been done to that analyzer. A little bit about purchasing and inventory. So inventory management is important. You want your inventory to be efficient and cost effective. So you don't want to be wasting a bunch of reagents because they're expiring, but you also want to have enough reagents. You have to store all this reagents, so you don't want to buy too much. And it's definitely not as easy as it seems. And there are programs out there that can help managers manage their supply, their inventory, so that they can be efficient and cost effective, and they're not wasting and throwing reagents away, which is throwing money away. So management negotiates purchase agreements and delivery of the reagents. And they negotiate and they decide also how much to order. Again, there are programs out there that can help you determine that, what users patterns you have. And then this can, sometimes that can vary from season to season. For example, this is not a chemistry specific one, but like flu kits, okay? You're probably going to go through a lot more flu kits, flu testing kits in the winter than you would during the summer. And so you might have to adjust your purchase accordingly. The lab staff is responsible for receiving the supplies in and properly stocking them. You want to, obviously, anything that's refrigerated goes in the fridge, freezer goes in the freezer, room temp, so putting everything in its proper place. But then you also have a responsibility to put the newer stock towards the back of the shelves, keep lots together, and move the older stock so you can use it up towards the front of the shelves, because a lot of times if you're just busy, your department is really busy, you run a bunch of tests, and you need to grab some reagents, chances are you're just going to open the fridge and grab that first box. And so if the person's stocking is conscious of keeping these lots together and keeping what needs to be used up first in the front, then when that tech comes and grabs the reagent, they'll automatically grab the right one if they grab the one that's in the front. All right, so first little question. So give me an example of a lab error, something that can, mistake that can happen in the lab. And so we're going to now look at the whole process control of testing, and we're going to start, obviously, with the pre-analytical phase. So most lab errors, up to 68% of lab errors, will occur in the pre-analytical phase, which is the period from the time a test is ordered, or from even just ordering the test, to the time the sample is ready for testing, and then we would enter the analytical phase. There are variables that are controllable and variables that are not controllable. And your controllable variables are obviously where all the preventable errors are, which is where the majority of errors would lie. This basically ties into ordering the right test on the right patient and then collecting the right sample on the right patient for that right test at the right time, okay? And so some of that has gotten better because of the electronic health record systems. Physicians are required to order their own lab tests on their patients, but sometimes it's easy in an electronic record to select maybe the wrong patient, and if you didn't double check that you selected the right patient, you might be ordering tests that you want, you're just ordering them on the wrong patient. It used to be, when there was paper charts, the physician would handwrite all the orders and hand them to a unit secretary who had to try to decipher their writing and stuff, and enter the test in the system. And sometimes they would get confused because they don't have any extensive lab knowledge, and so they would order the wrong tests, and that can waste time and resources and money. Then, of course, you also have the responsibility of the phlebotomy team to properly identify the patient, collect the right sample, do it at the right time, get it back to the lab in the right conditions, and all of that with the proper documentation. Some of the variables that are not controllable will be diurnal variations of the analyte within the patient. So there are things like there are analytes that vary, and so obviously documenting the collection time is really important for those, but they simply do vary during the day, and there's nothing you can do about that other than control like the testing time, the ordering time, the collection time. So collect it at the right time. And there are also physiologic factors that can have to do with, the tourniquet being on, or with, the state of the patient, if the, things that are going on with the patient. Those are things that you really can't control. But doing properly identifying patients, getting the right tests, the right tubes, and all of that are things that can be controlled. So, a little deeper into pre-analytical phase. So the pre-collection has to do with, again, ordering the right test, but then on our lab phlebotomy team part would be to identify the patient correctly, usually using two identifiers. The easiest identifiers to use are name and date of birth. But now, one of the things that you have to be very careful is that as much as you possibly can, if you're out there collecting, being a phlebotomist or simply a lab tech collecting samples, is you want the patient to identify themselves to you. So you would want to do something like, good morning, my name is such and such, I'm from the lab, I'm here to draw some blood, could you please tell me your name and date of birth? And then they will say whatever, and you will check that against your orders and make sure that you indeed walked into the right room, that they haven't moved your patient, and that you do have the right person in front of you. And so if you don't do that, then it can cause a need for redraws because you could have stuck the wrong patient and then label them with this other patient's name, and it can cause all kinds of problems. I have found, this is especially true with patients that have dementia. If you walk into the room and say, hey, Mr. John Smith, I'm here to, draw your blood and all that. Or is your date of birth such and such and such and such? And if they have dementia, even if it's not their name, they may say yes, okay, because they have no clue. They don't know, okay? And so proper patient identification is really, really critical. So obviously you want to collect the proper specimen, the right tubes, the right order of draw, etc. You want to label your tubes properly, so put the right test label on the right tube with the time it's been collected in your initials. You want to be careful when you collect to not cause hemolysis. This is what a hemolyzed sample would look like. This is where you want it. This is just the plasma or serum off of one of those. And you want to avoid clerical errors. Again, clerical errors can be, not having, misreading stuff or not documenting things right, or, flip-flopping numbers or different things like that. And then processing the specimens back in. Every specimen that's been collected and comes back in the lab needs a lab check-in time and other pertinent information such as who collected it. And then they're processed. Some of them might be just sent to hematology. The chemistry 1 tubes, if it's a clot tube, will be allowed to clot fully. If it's a green top, a heparin tube, they can be loaded in the centrifuge and all that. But then after centrifugation, if they need to be split, it can be aliquoted into other tubes and stuff. But you may have to sometimes reject a sample because there's not enough in there, or because when you spin it down, it's completely hemolyzed and there's nothing you can do with it. So you should catch this at processing ideally. The lab check-in time is important because sometimes it can help track what's going on in the lab. So don't assume that when you have a specimen, they just went out to just draw that specimen and brought it back to the lab. It could be that the phlebotomist had like 5 different orders. They went to 5 different patients' room, and then they came back with all of their samples and checked them all in. And obviously, they're all going to have different collect time, but that first sample has been sitting on their tray for, who knows, 20 minutes, 30 minutes, 40 minutes, depending on how fast they are. 20 minutes is a little bit faster if you have 5 patients. But, so, you can catch what's going, my drift of what's going on there. Those can help you sometimes piece something that's going on with your sample, if it sat on a tray for too long, or if there was a delay between the time it was collected, the time it was checked in. Oftentimes, too, we talk about that in automation. If the samples aren't checked in, then the information doesn't cross over from the LIS into the analyzer. And if you load a tube on your analyzer that hasn't been checked in, the analyzer doesn't know what to do with it, so it does nothing with it. And then you could be thinking that the sample's running, and when indeed there's actually nothing going on. Anyway, also how it's transported to the lab, how it is stored after it's collected, whether or not you retain the sample or it's thrown away, if you do retain, which a lot of times we do retain our samples, how long do you retain it for? Do you retain it for the duration of the shift, 24 hours, 48 hours, 5 days, a week? Like, how long do we keep them? Okay, next question. So give me an example of an error that would occur in the pre-analytical phase of testing. So be thinking about that. Okay, so now let's move into the analytical phase. So instrument function is very important to the process control of the analytical phase. So many analytical phase errors will occur as a result of a mechanical malfunction of the instrument. So these could include aspiration of the sample, the dispensing of reagents, the age of the lamp, the age of the IC module, the function of the various pumps that are often contained in the automated analyzers. There are a bunch of moving parts, a bunch of things that's going on, and something can go wrong at any time. You want to use proper reagents and calibrators and all that to maintain quality. This is usually what is provided to you by the manufacturer. You really don't want to go outside of what is provided by the manufacturer, even if it's supposed to be compatible. Again, reagents have to be properly stored, and you want to make sure that they are calibrated at the recommended frequency according to what the manufacturer recommends. Obviously, you would calibrate every new lot number, but sometimes if you have a lot number that lasts a long time, you may also have to calibrate them maybe once a month or something like that. Technical competence of your staff. There's usually an annual assessment of lab techs that are operating that machine to make sure that they know how to properly do things such as maintenance and replacing, or refeeding like basic things like cuvettes, or emptying waste out of that machine, or reloading different fluids and reagents and all of these things. So yeah, every year techs have to go through a competency checklist of some sort for every equipment that they run. And then the ancillary equipment, or equipment that are related to the functioning of the analyzers. And so this could be like heat blocks or water baths if you have to warm something up. We had an instance one time of, so sometimes if your quality control is not working right, you may have to rerun it. And sometimes, or you have to run a new bottle, sometimes they're frozen. And so then you're like, well, that takes a long time, but I need to get this done. And so you could take these frozen vials and stick them in a 37-degree water bath, and it thaws them out faster. But if your water bath is set too hot, I had a tech one time do that. They turned it up to thaw it faster, but the thing is, when they turn it up too hot, and then it denatured a bunch of the proteins and made some of these assays not work at all because they got too hot. So things like that can impact, obviously, your testing, your refrigerators and freezers. You have to usually do some kind of daily documentation of their temperature to make sure that your freezer's not all of a sudden on the fritz. Like, that would be terrible. You open your freezer with all your frozen quality control and calibrators, and only to find out that the thing is not working at all. Everything is thawed out, and nobody has documented the freezer temperature in the last 2 days. That would be just terrible, because you would lose a lot of the materials and stuff that were stored. So that's part of quality, is to make sure that everything that you have is operating adequately, that your centrifuges are operating adequately, that they're spinning at the right RPMs for the right amount of time, etc., so that you have ideal specimens to test. Okay, so let's talk about control materials. So control materials are usually purchased. They can be purchased from the manufacturer, or they can be purchased from companies like Biorad is a big one. And they will contain a specific amount of the analyte, and a lot of times the controls have a blend of the different analytes, so that they would, you can have controls for like all your regular chemistry tests, but then you can have a different set of controls for all your cardiac tests, and then a different set of controls then for all your drugs, and et cetera, et cetera. And they're tested just like patients are, so in a way you kind of treat them just like you would a normal patient. They usually are 3 different levels, so that could be sometimes a low, normal, and high, or the low could be your normal, and it can be a little bit high and really high. It just kind of depends, but it should definitely test the range of your analytical measurement range. So that you know that everything is, your analyzer is operating ideally and precisely and accurately at all ranges of testing up and down the analytical measurement range for each assay that you're doing. Always use at least a normal and abnormal level. That's the bare minimum daily. And so different labs will handle things differently. Some labs do 3 levels every day. Some will do 2 levels once a shift, so they're doing 2 levels every 8 hours, but they're rotating which levels they're doing. So I've seen labs do like maybe 1 and 2 on first shift, 2 and 3 on second shift, 3 and 1 on third shift. So they're running quality control every 8 hours. And then I've seen labs that just simply do all 3 levels once a day and do it every 24 hours. Right. When you buy control materials, you usually buy enough to last months, if not at least a full year. Reason being, you don't want to be switching up lot numbers, because every time you switch lot numbers of quality controls, the ranges of each analyte, of the target ranges can shift, and it can take a little bit to adjust. And normally when you are preparing to switch lot numbers of controls, you actually need to have an overlap of the old and a new lot number that is at least of a month, so you can run both of them in tandem and see how they're comparing. And you have a whole month of data on your new quality control set before you launch it for real. And that's ideal if you have a good, well-run chemistry department. The forms of control materials vary, and they're definitely of the same material as a sample, so they come from serum and plasma, so they're real biological materials. They can be frozen, lyophilized, or liquid. And so sometimes they're simply refrigerated liquid, sometimes they're frozen liquid, sometimes they're frozen lyophilized. Well, lyophilized always comes frozen, but then you set it out. Lyophilized is the same thing as freeze-dried, and so those are the ones you would have to reconstitute with clinical lab reagent water or diluent of some sort, whatever it says on there, that's what you use. You have to make sure you measure the right amount, so if it says 5 mils, it better be exactly 5 mils. If they're liquid, it's pretty easy. They're frozen liquid, you just thaw them out. Okay, so that's pretty straightforward. And then there are assayed and unassayed controlled, and so that has to do with what you want to purchase. Assayed are always more expensive than unassayed. The difference between the two is this: assayed controls come with a predetermined range that's already set for each analyzer type and each analyte. So you already have a target. You can look up. They can give you the data to say, for your type of analyzer, for this analyte, level 1 should be this, this range, level 2 should be this range, level 3 should be this range. And so you already have a target to aim at, and then you can adjust it slightly, that range, for your lab, as your, each analyzer is slightly different. So an unassayed control, then you don't have a target, and so you would have to set the range. And the way you would set the range is when you do that whole month of parallel testing, you're using all those data points on the new lot for every tests for every level of QC to determine what the range is going to be for this new lot number of QC. And I say it again, I said are cheaper. So again, you need to do a lot-to-lot correlation for the control materials. And so this is called parallel testing. Just like we talk about parallel testing between an old analyzer and a new analyzer, you do parallel testing with the current control material you're on and the new control materials that you're fixing to switch to. At the bare minimums, they need to be run 20 times in 20 days. This is not run them 20 times the same day. This is run them at least once a day for 20 days. That's the bare minimum. And you run it alongside your patient tests while you still have your old lot number of controls running, that's making sure that your analyzer is functioning properly. And then you set the mean, and the standard deviations tend to usually stay the same. And then you can go and start running with it. If you get a new reagent lot, and you have to do often some patient correlations, but at the very least, you've got to do, with a new reagent lot, at the very least, you have to calibrate it, run your controls, and make sure that your controls are in, and you can actually report out some, your patients, and to be accurate on that new reagent lot. So how often do you analyze quality control material? Again, a lot of that is determined by the manufacturer, but at the very least, you want to do it after maintenance. So a lot of times you would do your daily maintenance and then run your quality control. Each time you have, you switch in to a new reagent lot, or you're doing a new calibration for some reason, or a new reagent calibration or something like that, quality control, you have to do it. At the bare minimum, once per 24 hours or once per shift. Again, all of that can be manufacturer determined, and then usually whatever the manufacturer says is the minimum, but a lab can decide to do more, but it has to at least meet the minimum. The calibrator materials, the materials that are used to set the calibration curves, which are different than the materials that are used to assess, the quality controls that are used to assess the performance of the test. So they are responsible for turning the signal, the absorbance, into a concentration. So if you remember, we had set these, like a calibration line here, where a set absorbance equals a set, a specific concentration. And if you move the line up or down, then it changes what the absorbance would translate as, which concentration it will mean. And so calibrations will set the limits of testing, so you can use them also to determine the linearity. So as long as this calibration line is linear, is straight, then you're in a good analytical measurement range. Once it starts straying, it starts flattening out or curving somehow, then you're out of linear. It's no longer linear or straight, then you can't be on that level, that concentration, that absorbance. You can't report out any kind of results. And then if you had a result that was too high to read, you would have to dilute it so that it would read within the linearity. Calibration are run every 6 months at the bare minimum. Again, a lot of that is going to be manufacturer determined. You will always run calibrations for each new lot of reagents. Always, like you can't even run the test until you've calibrated it. And you can also use calibrations to troubleshoot out of range QC. So sometimes all it needs is the test needs to just be recalibrated, and that fixes your problems. So it's one of the tools that you can use to figure out what's going on with your analyzer. So quality control on the analyzers is an essential part of the quality management system, and basically it determines whether patients can be tested on the analyzer. If you are running your quality controls, which you know what the target values are for these, those quality control values, and you're not getting accurate results or reliable results, then you have no business turning out patient results, because that means your patients results aren't going to be accurate or reliable. So the goal of quality control on these analyzers is to detect, evaluate, and correct errors before the results are reported. And so until you resolve your quality control issues, if you're having some issues, you cannot report any of those patient tests out. So it has to fall within control limits, which we saw in the assayed controls were determined by the manufacturer, and the unassayed have to be determined by the lab. And those control limits are usually the mean plus and minus 2 standard deviations. And so that usually gives you a range of concentration that is listed as, 100 milligrams per DL to 120 milligrams per DL or something like that. So it has a specific concentration from low to high, so that when you get a result, oh, my quality control result is 110. Well, that is within the range. I'm good to go. Okay, oh, it's 125. Oh, that's too high. I'm outside, so we need to troubleshoot that. So it makes it very easy for you to see if your controls are in or out. And that determines accuracy and precision of the analyzer. So accuracy has to do with validity or how close to the true value it is. So if we look at these targets, the true value is the center. Okay, so and if your analyzer is hitting center every time, it is accurate. So these two are actually both representations of high accuracy. These are representations of low accuracy because they're off center. They're hitting below here and off to the side on the target, and these are hitting in the middle. So these two are accurate because they're hitting the target value. So that means, for example, if your patient's actual glucose in their specimen is 88 and you're testing it on your machine, you actually are getting 88. Okay, that basically is what it translates to. Precision has to do with reproducibility of the results, so that if you ran that same patient over and over and over and over and over and over again, and that patient was 88, are you getting 88, 88, 88, 88, 88 every time, or are you getting 88, 86, 90, and then 87, and then 89, and then 88, and then 92, or something like that? So if you're getting 88, 88, 88, it's highly precise. Both of these here represent high precision, meaning all the dots are very closely together, meaning that you're hitting the same point every time. So you're hitting the same value every time. It's just this one is precise but not accurate, because it's precise because they're all together, but it's not accurate because you're off from true value. Okay, and this one is both precise and accurate. These show low precision because you can see the dots are kind of scattered around. It's meaning that every time it's hitting a little bit off from what it's supposed to be, and so this would have low precision. So what you definitely don't want for your analyzer is low precision and low accuracy. You're like off center and all over the place. You do not want that. And so here you're accurate, but you're imprecise, meaning you're kind of hitting all over, but they're still around what the true value is. Okay, so for this little question, think about this. So if the target mean for glucose in QC1 is 85, and the QC values over the last week are 81, 80, 82, 83, 80, 79, 71, what would it be? Either is it good accuracy, poor accuracy, is it good precision, poor precision? What combination do you think? Think about that and answer me that on the activities if you are in my class. All right, so let's talk a little bit about statistics. So I did mention that the quality control range is usually calculated as the mean plus or minus 2 standard deviations. So these are statistical variables that can be calculated. So the mean, you should know what it is, but to get the mean is you add up all of your results on that specific analyte on that specific quality control level, right? All the results are added up and they're divided by the number of results and the number of points that you have, the number of results you have. So if you have 30 days and you have 30 results, you would add all 30 of those values together and divide them by 30, and that would give you your mean. And so the computer does that for you. And then a normal distribution kind of follows this pattern where the majority of the points are going to be, the values are going to be around the mean. Big chunk of them, so this is 68% of them are going to fall within one standard deviation above and below the mean, okay? And 95% of them are going to fall between 2 standard deviation above and below the mean. And so 99% of them will fall between 3 standard deviations above and below the mean. And so we usually research and quality control in the lab have determined that 95% confidence level is adequate. So we can say that as long as the points fall within 2 standard deviations above and below the mean, it's 95% confidence level here. We can say with, pretty good reliability and stuff that our testing is accurate and that we're good. If it falls outside of 2 standard deviations, then there's a problem with that analyte and with that particular control level. And so the standard deviation is basically the amount of variation around the mean. And so, the wider this is, the more scattered the points are. This is a calculation that is done by the computer. There's a way to manually calculate that, but I'm not going to make you do it. But your computer, and you can even do that in Excel, will calculate based on a set of points, data, and stuff like that you put in. You get the mean, but you can get the standard deviation also. The coefficient of variation is basically the standard deviation divided by the mean times 100. And it monitors precision. So the mean and the standard deviation really assess accuracy. Okay, so the further away you are from the mean, the less accurate you are. The coefficient of variation will tell you how tightly around the mean these points are. And so basically it also has to do with the shape of your curve. Is your curve kind of like wide, or is your curve like really tight? Your normal distribution curve is really tight. Generally speaking, in the lab, for a chemistry test, you want your coefficient of variation, which is calculated by your analyzer, to be below 5%. So if you're less than 5%, that means you have good precision for that specific analyte. If you're above 5%, then you're having some precision issues with that analyte. And ideally, less than 3% is even better, but 5% seems to be a good accepted number. So reference ranges are something different than quality control ranges. Okay, so quality control ranges are, again, mean plus or minus 2 standard deviations, and it will tell you whether your quality control for that analyte at that specific quality control level is running if your test is accurate. If your test is accurate, then you can turn out patient results. Reference ranges are what is normal for the average person. That's what reference ranges are. So, for example, for your normal patient, you would expect a glucose between 80 and 100 milligrams per deciliter. That would be average. So that means that 95% of normal people would fall in the normal range. Okay, and so that gives the physician some decision limits to see if you are normal or not, and how do you fall in comparison to everybody else in the population. If what you're monitoring is a drug level, then we don't call them reference ranges or normal ranges. We call them therapeutic ranges, because normally healthy people are not on those drugs, right? So then they're therapeutic ranges. Reference ranges are usually determined by the manufacturers for their assays, because you need hundreds of normal samples to determine these. And then when you get that specific assay into your lab and you're going to implement or whatever, you can verify for the population that your lab serves by simply running 20 normal samples. And so these are samples that are free of, the patient doesn't have any specific diseases and all that. They're usually normal, healthy adults with, no underlying conditions or anything like that. And not on any kind of medications usually also. Okay, so next poll question. So if your level 3 AST controls show a CV of 6.5, this shows that at the high end of the linearity range this test has, and then pick which, is it accurate or is it precise or is it inaccurate or imprecise, basically is what you're looking for. This is a little matching activity for people in my class. You can do that. Okay, let's talk a little bit about method evaluations. So there are many methods and tests that are available. So we have in this class already discussed immunoassays and all the different types of immunoassays. So let's say, for example, you had a TSH test, and you can have different methods to test that TSH that could be available to you. So you could have a TSH that's a test that's an ELISA and an enzyme-linked immunoassay, but maybe they have this new chemiluminescent TSH method. So that's a different method. It's the same test, but it's a different method. And so when you decide, do you want to switch to this new method? Is it worth it or not, etc.? You got to consider several things. The cost of the testing. So is this new method more expensive, about the same? Like, is it worth it? The time required for testing. So maybe it's a newer method, it's a little bit more expensive, but it gets you results like in half the time, then maybe that's worth it. All right, so these are things as a manager that need to be considered. And then what are the quality of the results? And those are determined by the accuracy and precision of that specific method for that specific test. And those are determined by calculating the diagnostic specificity and sensitivity. So specificity and sensitivity for that specific test. And so the specificity is the ability of the test to detect the absence of a disease. So meaning like you don't have it and you actually are testing negative. So it's the percent of the people that are without the disease whose test is negative. Okay. And this is calculated using your true negatives. That means the patient doesn't have the disease and the test was negative. And your false positives, meaning the patient does not have the disease, but somehow you got a positive test for them. Okay. And I'll show you on the next slide how these are calculated. And so your diagnostic sensitivity or sensitivity is the ability of the test to detect a disease in someone that has the disease. And is calculated on the percent of people who have the disease whose test is positive, and it uses the true positives. So true positive means has a disease, the test is positive, and the false negatives meaning it has the disease but the test was negative. Okay. And linear regression can also be used to correlate two methods, and that's a footnote apart from specificity and sensitivity. Linear regression is another statistical calculation that can be used to see if two methods correlate adequately, where if you switch from one to the other, you don't have to switch your reference ranges and all that for your patients. Okay, so let's back to specificity and sensitivity. Okay, so if you look in this little table, disease status, the test. So the subjects that have the disease and test positives are your true positives. The people that have the disease that test negative are false negatives. And your sensitivity is calculated by taking the true positives and dividing them by the true positive and the false negatives. Okay, and that gives you a percentage. And you can have, say it has a 90% sensitivity. Okay, so that means it's 90% of the time it's right at telling you this person is sick with a disease. Okay, and then the specificity, it allows you to rule out people saying that they for sure don't have the disease. So you have people without the disease, and if they test positive, it's a false positive. If they test negative, it's a true negative because they don't have the disease. You take the true negatives divided by the false positive plus the true negatives, and you again get a percentage. Should be again high. You want in the 90 plus and above specificity, and then that would mean that it is good at ruling out people saying if it's negative they for sure do not have that disease. Also, your quality control needs to be analyzed and reviewed. So there are two types of errors that can occur in quality control. There are random errors and systematic errors. So random errors are infrequent, and they can be positive or negative, meaning they can be too high or too low. You remember you have your range, which was your mean plus and minus your 2 standard deviations, and so it fell outside, but above it, that's too high. That's a positive random error. It's up, and if it's running below your 2 standard deviation mark, it's too low, or it's on the negative. It's less than minus 2 standard deviations. An example of how a random error could happen would be when you're loading your quality control. So you had level 1, level 2, and level 3, and you were loading them in little cups, pouring them into cups that have specific barcodes that identify level 1, level 2, level 3, etc. And let's say you poured up level 1 and you set it down, and then your phone rings on the department, you answer the phone, and then you get back to what you're doing, and you pick up level 1 again and pour it in the level 2 cup. And then you don't realize your mistake until after you run all your specimens, and everything that's level 2 is going to have results that are off because you loaded the wrong quality control material. This could also happen if you ran, if you loaded your cups with cardiac controls instead of drug controls or something like that. You got them crossed and mixed up, and so things like that can happen. If there's bubbles, there's insufficient sample, all of that. And just random errors are just one-offs. And they're usually infrequent, and there's just a blip in the process, and it's usually pretty easily fixed and remedied. Systematic errors are consistent errors. So they're a consistent shift in one direction or another. So it usually means that all of a sudden maybe you were around your mean, and then all of a sudden it shifted up, or all of it shifted down. And so in systematic errors, it does have a specific direction. So it's not that you're going to have some up, some down. You're going to have either all of them up or all of them down from the mean. And within those, there are both trends and shifts. So trends look almost like a stair step. It's trending up. So you have 6 controls in a row that are either going up or going down. Okay. And so it usually indicates some kind of gradual deterioration. Maybe your reagents are going bad, or there's a problem, the lamp's starting to go bad, or something like that. But it usually indicates a problem with like the machine, the calibrator, the reagent, or something like that. It could be also deterioration of the controls itself. A shift is a sudden change, so it means that you were at this level, and all of a sudden everything shifted, and now everything's at this level, or it shifted up or shifted down, and so you really see an abrupt change, and then everything's at this other level, and these are often seen if you have a new calibration or a new reagent lot or something, and it caused a shift in your mean of your quality control. Both trends and shifts are seen on a Levy-Jennings chart. And so I'll show you what this looks like, and this is how you can see if you have a shift, a trend, or a random error. Okay, so you would have, look at this is Levy-Jennings graphs. So you would have this, you would have one of these per control level per test. So this is control level 1, and we can say one specific test could be it's a glucose or something like that. And then if you have control level 2 for glucose, it's going to be a different one of those graphs. And then control level 3 is going to be another of those graphs. Okay, and we're going to look at some of those in the lab if you're in class with me. And so I'm going to see if this drawing thing works here for a second. And I'm going to do red. So with this control graph, you would have here, like, it plots, these are the days. So on the first day, it's going to plot the point and wherever it is. So there it's right here. And then the next day, it's right here. And then the next day, it was this level. And, you know, the mean it's the mean concentration here, right? And then it goes here, and then it's here, and so on. And so it usually ends up with some kind of pattern that looks like this, if you're good. If you're trending, then all of a sudden it could look like something like this, going down. And then if you shifted, it could look something like, so it was here, and then all of a sudden this is going here, and then all the points are over here. Okay, so that would be a shift. This would be a trend. Ideally, you want all your points dispersed around your mean within your 2 standard deviation lines. You don't want them out at 3. If you had a random error that maybe this point was actually all the way over here, that would have been a random error. Okay, so I'm going to erase all of that. So that gives you an idea of what's going on there. So these Levy-Jennings can be viewed on the analyzers for every test, every level of quality control, and usually for more than 30 days. Usually however long you've been running, you can view these charts. And so this allows you to analyze and see what's going on with your test, and it can help you make decisions on how to resolve what's going on. Okay, so this is also another type of chart. It's called a Youden plot, and it looks both at normal and abnormal QC together. So where you would have, you know, like this, maybe this is abnormal, this is normal values, and then it plots the points, and then like the middle would be the mean. This would be 1 standard deviation. The red line is 2 standard deviation, and you would want everything in that box. And this one would be something that would be outside of the range and all of that. I've not used these very often. Levy-Jennings is what's being used the most. So we're going to continue with Levy-Jennings. Sorry. Yeah, I'm sorry. I thought I clicked twice. Okay, so to analyze these Levy-Jennings charts, then there is a set of rules that are called the Westgard rules that we can use to denote what's going on with our quality control. So, for example, if you have 1 point that fell outside of 2 standard deviation, you can denote that as a 1, 2s. So 1 point outside of 2 standard deviations. If you have 2 points outside of 2 standard deviation, 2 in a row, it has to be 2 in a row. It can't be it was out and then a few days later it was out again. No, it's back to back. They're 2 in a row. Then that would be a 2 points, a 2s. Okay, 2 points outside of 2 standard deviation. This can be above or below. Okay, and then this little guy, or shown right here, it is outside of 3 standard deviations. This is 1 3s, 1 point outside of 3 standard deviations, which is not good. You do not want to be falling that far out of the range. Then there are some other ones that we're going to see. This is a 4 1s. So these are 4 points that are outside of the 1 standard deviation line, which is not portrayed here, but lies about here. The midway between the mean and the 2 standard deviation line is the 1 standard deviation line. And so if you have these points are starting to congregate on north or south of that 1 standard deviation line, then you're looking at a possible shift or a possible trend, and you could be getting into trouble. So it's like a warning to look at it and see what's going on. So that's a 4 1s, 4 points outside of 1 standard deviation. Then there's an R4s. This definitely indicates a lack of precision, and this is when the difference between 2 consecutive points is more than 4 standard deviations. So this one, it goes from being out below 2SD to out above 2SD. This is not good. This is too big of a jump, and if you have a lot of them, it could be an indication of a problem with precision on your analyzer. And then this one is a 10x, and there are 10 points in a row that are on one side of the mean. They're all on one side of the mean. So they're all below the mean. They could all be above the mean, but the point is they should be scattered around the mean, and they're not scattered around the mean. They're all below, all above, and there's at least 10 of them in a row. So that, again, can indicate, depending on the direction, if it could be a shift or a trend. It's something you have to look at the whole graph to decide what's going on. Okay, so match up some of these definitions we just looked at, and then I'm going to skip the quiz for the video, but if you're in class, you're going to have to do the quiz. And so if you are at the bench and you're running your daily quality control, then how do you use all this to make decisions? So this gives you kind of a thought process workflow. So you ran your controls, and there's a control outside of the that violates the rules. It's outside of 2SD, it's outside of 3SD or something like that. Okay. Your first action is always going to be to repeat the run. And this is if you're working at the bench that day, that's what you do. Okay. And so you literally simply go grab the vials again, mix them up real good, reload all that QC fresh, and run it again. Okay. At least on those analytes that are out. Okay, if the QC is okay after you reran it, then you can just report the test results of your patient's test results, and you can move on. You can continue running patients and report those results out. Okay, you're good to go. If you reran those quality control and they are not in, then your next step is go get a fresh bottle of the level or the levels that you're having issues with. So that means you're going to go in the fridge or the freezer or whatever, grab some more, make sure they're at proper temperature and all of that, mix them really well, and load it again and run it again. Okay, if those worked, then you are going to want to take a look at your, evaluate it using your Westgard rules and kind of go look at your Levy Jennings and make sure like what's going on with the test. Are we back in? Are we good to go? And then decide from that whether or not you can keep reporting patient results out. If that didn't work, then you have essentially ruled out a problem with the control material itself, and your problem now it's indicating that the problem is in the analyzer. So it could be an instrument problem, it could be that it needs maintenance, or it could be that your reagents are going bad, deteriorating. It could be a reagent issue for that test. Okay, so then you have to check on all of that. Maybe you do some cleaning, maybe do some maintenance, maybe you see that your reagent on that assay is like, oh, it's at the end of its life, it's almost empty or whatever, and maybe you swap out to a new one of the same lot number, load some fresh reagent on there and stuff. And if that fixes it, you can repeat your patient specimens of what you've been running, make sure everything's good, and your quality control is in, all of that, right? You can report out your patients. If swapping to new reagents or doing some maintenance and stuff like that didn't fix it, your QC is still out, then because you reran your QC after you did your maintenance or changed your reagent, then you are going to recalibrate and run your QC again. So like that means we've run QC like 4 or 5 times by now, right? And if that works, then you can repeat your patient specimens that you had run and start turning out patient results. So that means that your quality control came in after you recalibrated. And if that still didn't work, then that's when you call tech support. That you're at the limit of what you can do. Sometimes you'll find out like, oh yeah, we've been having some problems with this reagent lot or something like that, but they can guide you in further steps to take with your analyzer and how to resolve that. Okay, your next poll question. So this is it a quality control graph or is it a calibration graph? What is this? Okay. Now let's talk a little bit about external quality control. So external quality control, one of the agencies that you can use for that is the College of American Pathologists, or CAP. And what they do is, so they're an external organization, right? So they're outside of your lab, is they send you some specimens, usually 5. And like I said, for chemistry, it would be 5 samples, and you have a list of tests that you have to run on those 5 samples. And you have to treat them like a patient. You have no idea what the values are supposed to be. You run your 5 samples on your machine, get the results, and plug the results into the survey that they give you and send it back to CAP. You cannot consult, you cannot send them to a different lab, etc. You have to treat them just like you would a patient. It needs to be performed by the same testing personnel, so you can't hand them off to the chief or bench tech or whatever, whoever's in charge. Your regular testing personnel has to have a turn at doing these, and it is performed right alongside all your other patients and treated again just like a patient. And so CAP gathers all the data back in on those samples and will report out what the target value was with a range and all of that for their specimen, and whether you fell in the close to that target or not, or if you were really off. And so basically it will tell you for each test if it's a pass, fail, pass, fail, pass, fail. Okay, you want to see pass, right, all the way down the list. And so that basically checks how your whole testing process is, and if you are indeed turning out accurate test results. If you fail one, then they're going to look at your next survey. So they send these every few months, several times a year, on every test that you perform in the lab. And if you get your next survey in and you fail that same test again, then you're really having some issues. If you fail a proficiency test on a specific analyte 3 times in a row, you will lose your ability to perform that test and to bill for that test. So that's a big no-no. So these are things that are taken really seriously by the lab, because if there is a problem, then that problem needs to be addressed, because that means that for that test, the lab is not turning out accurate results. And so it has to be taken very seriously. So big stuff. And every lab has to do some proficiency tests, some level of proficiency testing. And now let's dive into the post-analytical phase. So this has to do with interpreting test results. Your reference ranges are always reported with your patient results, so physicians can see right away. And then often the results are flagged high or low, or critical high, critical low, or something like that. And sometimes the meaning of abnormal results may not always be well understood. Sometimes the physicians may call the lab, needing some more education. What does this mean if this is high, etc. They should be trained in interpreting lab results, because sometimes they need help, especially if it's an odd, unusual test. And so we talked a little bit when we talked about automation about auto-verify. So, reporting test results. Auto-verify is used when there's just nothing abnormal about those test results, and it can just move straight through the system. But the LIS system, so the lab information system, which is separate from the analyzer system, can be used to flag results, things that are like not matching up, or that are really like critical high or critical lows and stuff. They do delta checks. So a delta check is, it checks what the patient has been running. What's the history of this patient for that specific analyte? And if it fails that delta check, that means that they're off from what they normally have been. Sometimes there's a legitimate reason. Maybe they had been running low in not a chemistry test, but like for their hemoglobin hematocrit, and then they got transfused, and they went up. Sometimes in chemistry, if they'd been running high on the BUN creatinine and then got dialysis and stuff, it can come back down. Sometimes you can throw delta checks. Anyway. And critical values have to be called to the nursing personnel, so you actually have to pick up the phone, talk to a human being, and tell them, hey, Mr. So-and-so, Mrs. So-and-so's glucose or whatever is this, and then you have to document who you talked to, and then that has to be documented into the lab information system. So it's kind of like hot potato. You've just passed on the hot potato to the nurses, and it's on them to act on it, and you have verified that you have talked to so-and-so, and if they don't relay that information to the doctor, or don't take care of the patient, or forget to tell the nurse that's attending to that patient or something like that, then it's on them. Okay, you have to document that you've talked and relay the information to the proper staff. A little bit about assessment and audits. So assessment can determine the effectiveness of your quality management system. It demonstrates that you meet all the necessary requirements that are set, all these standards that are set, and that you meet the accreditation standards and stuff. So a lot of places, like if you're CAP accredited, are going to be audited or inspected by CAP inspectors. They show up at the lab and look through everything to make sure that you're meeting all these requirements and stuff to be CAP accredited. So internal audits can be done first. Usually they're done before the CAP people show up. And the management team usually does that, and they look, are you meeting the current standards? Are your policies working? How's everything going? And then external audits are your accrediting agencies that come in and start looking through all your stuff and see, look and see, are you meeting the standards, etc. And part of that is a continuous quality improvement cycle where you see maybe a problem, something needs to be fixed, you put your plan in place, and then you monitor what's going on and see if your plan worked. If it doesn't, you do some corrective action, modify your plan, etc., and then you evaluate again. And so it's called a PDCA, plan, do, check, act. Okay, and so sometimes you make a plan and the plan doesn't work, or the plan doesn't fix the problem because it's not actually addressing the problem or something like that. And so this is a way to continuously address issues and to move towards higher quality. And this can apply to all kinds of processes within the lab, all the way around, and then all over the hospital too. Of course, personnel is your most valuable resource in your lab. They must participate in the proper training, so they're competent in their jobs. You need to maintain records of professional development, continuing education credits, all in services, and all the things that they have to go to. There are competency assessment checks that are required by your accrediting agencies. So they're required to check that, you're supposed to check, usually yearly, that your staff knows what the heck they're doing, basically, and it needs to be documented. And it's not just sometimes a checklist. Sometimes they'll give you some unknowns and say, okay, here, run these and see what you get. And or give you, if you're in hematology, give you some slides to diff and see if your diff is on par with everybody else's or something like that. And so these competency assessments for each individual, for each person, employee in the lab, will detail all the expectations, the past performance of an employee and current performance of an employee. And you need to do that so the employee can perform their job. Maybe they're not that good at diffing and needs a little bit more help and a little bit more in service, more practice and stuff like that, and you can address that. Lastly, customer service. So we need to meet our customers' requirements. Our customers obviously are our patients, but there are also our doctors that are ordering the tests and stuff, and the nurses that are treating the patients. And so even public health agencies to which we report our results or reportable results to and all that. And so we have to make sure that we adequately serve all of them. And the hospitals often use surveys, at least out for the patients, to assess how we do. How was your visit to the lab? Were you greeting? How was the phlebotomy? How was the team? How was the employee? How was the testing process? Did you get your results? Was things explained to you? And all of that kind of stuff. And then the lab is rated on these things. A little bit about occurrence management and process improvement. Occurrence management is documenting errors in near misses that are happening in the lab. So like if you see a pattern, this allows you to pick up on patterns. If you didn't document this stuff, then you may not, pick up on patterns and stuff like that. Near misses, again, errors in near misses means an error almost happened, but it was caught before it was sent out, and this is ideally what you want. But then it's the fact that it was a near miss. You have to look at the process of testing and all that. What happened and how could we have prevented this? This is a proactive process, and it's always ongoing. An occurrence would have a negative impact. So an occurrence usually means that something bad happened or something negative happened on the patient, for the patient because of an error in the lab. And so again, we talked about a part of this continuous process improvement is the PDCA, the plan, do, check, act. So you have a problem, you put a plan in place, activate the plan, check, make sure it's actually working and stuff like that, and then act. It could be like it becomes a permanent solution, or sometimes it's like, oh, it doesn't fix it, let's try something else. Lean and Six Sigma are also quality improvement tools. Lean looks at eliminating non-value adding steps, and Six Sigma also trying to reduce variation in processes and stuff like that. So there are actually manufacturing principles that can be applied in the lab to make things run better, more efficiently, and with more standardization between the text and all of that so that you turn out good results. And in your quality indicators, we definitely are looking at our contribution to patient care. Here, this little here tool, part of Lean Six Sigma, it's like you define the problem, but you have to measure it also. So usually you have some values you measure to define the problem, and then you have to get those measurements and then analyze those measurements and then decide on how to improve, do the improvement, and then you control or check to see by measuring again to see if that fixed the problem and stuff. And then you just keep going from one problem to the next, so you keep trying to improve stuff. A little bit on documented records. So in the lab, you should be able to find or have access to all the policies, processes, and procedures. So everything and anything that can be done in a lab should have a procedure, something that you can look up if you're like, how do we do this? And you don't have anybody to ask, you should be able to go to a procedure to look it up and to see how you're supposed to do X, Y, Z. Procedure manuals can be electronic or on paper. And each procedure has to contain certain information, so like details on how to perform the test, the type of specimen that's needed, what you need to perform the test, etc., etc. Your quality manual will contain your quality management system, and records are lots of records, lots of paperwork are generated by laboratory processes. Instrument printouts have to be kept for 2 years, and these are the printouts off your analyzers, etc. And patient records are much longer, especially if they're paper. But yeah, after 2 years, you can destroy your instrument printouts and stuff. Got another little matching exercise, and we are done. That was the last slide. So thank you for your attention in this rather long lecture, but important, and have a good day.